Thank you. Thanks, Dr. Sang, for your introduction, and thank you very much for organizing this meeting. And also it was a great pleasure to share with our results with our colleagues all over the world. And it's interesting. This format is actually looks like is working quite well. And today, so I will talk about some of the work we did. I'm talking on behalf of the China Consortium on Chest CT Imaging Investigation. So it's a CCCC two project, and we have another one on X-ray, and which has another acronym for this. I don't have to actually tell you how important it is to diagnose COVID-19, and computed tomography has been an important tool in non-disease diagnosis, including pneumonia. And obviously, this is actually take on a more important meaning in COVID-19 because of the shortage of nucleic acid-based testing methods. And in addition, CT can give you this quantitative measurements of lung lesions. So with all that caveats, and at least in China, at the initial outbreaks, and radiologists and the hospitals had been focusing on using CT for diagnosis of COVID-19 pneumonia. So there, just like Dr. Shen said, there are a number of issues in using the CT for applications of the COVID-19 diagnosis and the prognosis. And what we did here is to actually build up two models, and one is for a diagnosis. And in order to build a very accurate diagnosis tool, we found that it's important to initially do a segmentation and build a segmentation network. Therefore, we our colleagues, radiologists, 40 radiologists, painstakingly painted pixel by pixel slices, which is about 5,000 slices, and from those slices, we'll train the classifier to segment those lesions, so 6 types of lesions, and then we also we actually classify. We then taking end-to-end approach to have the computers learn these other features of the lesions. That's one, and the second one is we take the lung lesion features, combine them with the clinical metadata, try to correlate number one with clinical features, and then also attempt to make a prognostic analysis. So this is actually, as the first results, we were able to segment different features of lesions. This is including consolidation, ground glass appearance, fibrosis, interstitial thickening, and pleural effusion, some of the important features of a lesion. And this is important not only just for initial diagnosis. We found that often for the patients who progress into severe cases, critical ill patients, and eventually they will, the lungs will undergo fibrosis. And those are patients are important to be evaluated through quantitative measurements. So fibrosis segmentation are important. And so shown here are some of the features of different lesions. We were also able to reconstruct into a 3-dimensional lesions volume, as well as space relationships. And shown here is actually on the right side is a video, which I will not actually play. I essentially give you a straight, basically a rundown of where the lesions are. And so as the first initial attempt to address the diagnosis of novel coronavirus pneumonia, we call NCP, and we took few thousands of patients and over 300,000 slices, and as a training and also internal validation cohort. And we did it against several other pneumonia, and as you can imagine, so as a screening tool, we first need to make sure that it'll give actually very high diagnostic accuracy to normal lung, and also will be able to differentiate with other common pneumonia. Here, that includes bacterial pneumonia, viral pneumonia, and other pneumonia such as mycoplasma pneumonia. As you can see, that it did actually perform quite well in this regard. We also was able to do some prospective studies, both in independent Chinese cohort as well as international cohorts. In the Chinese cohorts, we took into consideration that different regions of China might have different rates of infections. For example, in part of the Wuhan, obviously, it is very high, infection rates are very high. So we did a prospective cohort there, and then I show actually it has very high accuracy. And then we also went on and did additional cohorts in the non-epidemic areas such as Anhui as well as Guangzhou, and those two areas, and which has the cohort. What we took is actually consecutive patients who came to the fever clinic, and obviously people come to, with fever with different reasons. One of which is try to make sure they do not have they don't have COVID-19 pneumonia. We use the standard nucleic acid based RT-PCR methods as standard measurements, and to make sure that we made a correct diagnosis. In doing so, that as you can see, we also achieved very high accuracy, overall accuracy of 90%. Another reason of using an AI system is to see how the AI system can assist our radiologists and ER physicians for the frontline diagnosis of COVID-19 pneumonia. In this case, what we show here is by training with about 300,000 NCP and other pneumonia cases, it can achieve quite actually good diagnostic accuracy. If you look at the panel C, so this is actually a weighted error, and it's about 9%, whereas the radiologist, average radiologist, the senior radiologist is performing comparable to the AI platform. But however, the junior radiologists are all over the place. If you look at the panel B, look at the initial junior radiologist performance, they are far beyond or far below the senior as well as the AI performance. In this case, we also allow the junior radiologists to assess the AI based diagnosis, and then I also show where the AI thinking, where the lesions are, and to give the junior radiologists opportunity to actually diagnosing the chest CT of the three categories. And this is again about 3 weeks later. We make sure that they don't memorize or remember what they have done before. As you can see, that this is actually the AI can dramatically assist and improve the diagnosis of the junior radiologists. So I think this is actually one of the more compelling reasons of AI, and we clearly actually see that the performance of a junior radiologist can be dramatically improved by the assistance of AI, and either using AI as a second grader, or actually or as a basic assistant with a first grader cases. So one other reason I thought actually it would be we thought it would be actually important for AI to perform is actually see how well the AI can predict other aspects of the systemic health. And the reason being that I think this is particularly important for CT, because the scanning of the lung essentially give us a quantitative measurement, so how big and small and how acute the lesions are. And because the lung function is directly proportional to the lesion size and the properties of the COVID-19, and we thought it had to be a way to essentially extrapolate and project the systemic health of the entire body. So this is actually, when we did this, we actually was blinded we don't have any knowledge because at that time, some of the prognostic clinical factor papers haven't been come out. We essentially use big data and the lung lesion, ask the question for essentially the correlation. As you can see in this slide, we actually show that age, C-reactive proteins, and albumin are highly correlated with the lesion size just by itself, by looking at the lesion size. And the lung and the liver function turn out to be, I mean, it's very conceivable that the lung function will be impacted on the lesion properties and size, and so as a saturation, CO2 saturation respiratory rate. However, what we didn't actually expect is actually the lung lesion properties was correlated very well with the other part of the function. So essentially, at the time, we thought that the lung lesion size or actually progression to the respiratory failure and be put on the ventilation, mechanical ventilation, essentially let us actually solely focus on the lung function. And this is actually AI-based non-hypothesis-driven search let us actually start to think about some other systemic factors are going to be impacting the outcomes of the severity and outcomes of the of those illness. So this is actually what we actually found, and so not only we found the correlation, we also are looking at the lesion size of the lung and the features plus the clinical factors. How would that actually be contributing to the progression to critical illness? By definition, those are admissions to the ICU, put on the mechanical ventilation ventilator, or death. And you can see here that clearly that the lung lesion play a major role. And then just by itself, we actually already give AUC about 83, 84%. And with the clinical properties, it can actually essentially raise up to the 90%. And in addition, we were able to stratify in figure panel E upon the admission of the patient to the hospital. What's the chance and how long it will take for them to progress into critical illness? Because that actually information is very important for the physicians, respiratory pulmonologists, the ER physicians, to strategize the strategy and allocating proper resources to make sure that we can alter the disease course in the beginning of the progression, such that we can reduce the ICU admissions. And because once we get to the ICU admissions, all the data show that there's a 60% mortality, and then a lot of actually things are already irreversible. Another function of the we thought that the AI can do is to for the evaluation of the drug treatment effects. So because of the AI, the CT-based AI system can do a beautiful job in quantifying the lesion size and properties. So in this case, we just took 3 drugs, and because at the time those drugs are still undergoing clinical trials, so we cannot actually break the envelope or seals for those drugs. However, we were giving the before and after treatment CT scanning properties, and we're able to look at the lesion size. You can see that, as you can see, clearly the CT can be used for measurements of the size of the lesion, as well as actually unique properties of the lesion. And you can, for example, quantify whether there's a reduced lesion, for example, or actually increased lesion or no change, or you can see whether there is increased fibrosis or actually decreased fibrosis upon on the drug treatment. So so I went very quickly on how we used this AI system for applications of several strategies for the applications. So some of the other issues is how fast and slow you can actually use a system to diagnose the diseases. So at the front line of the hospitals, for example, our system was implemented into several hospitals in Wuhan. which was the epicenter in the initial outbreaks in China, and it was important for the radiologists to actually be able to upload the images to the system and obtain a diagnosis very quickly. So we thought actually we can actually resize some of the images, DICOM images, and quickly, and then resize back to make a diagnosis. So this is some of the methods we use, and you can actually look at the in the details for the strategy if you like. So in summary, so we developed the AI system for the diagnosis of COVID-19 pneumonia based on chest CT. The system performed comparable to that of a practicing senior radiologist with significant clinical experience, and it can actually assist and improve the performance of a junior radiologist. And so I think this is actually a particular good example, an important point for an AI system, especially in an emerging disease. For example, if we have another Ebola virus or another pneumonia virus for pneumonia, it is important for us to quickly build a system that can be applicable and then can help the radiologists, even the senior radiologists who hasn't seen this type of lesions, to quickly bring up to speed. And we also did work on correlations of lesion features in a CT scan, as well as markers for multiple organ failures, and highlighting the multiple organ failure as an important feature of mobility and mortality. So for example, that we identified CRP as the important marker for organ failures. And then this is actually just to highlight the systemic inflammation as an important marker. In addition, we found actually a number of markers in liver, and for example, some of the transamylase and albumin and LFTs are important for progression to the severe illness, and also the D-dimers and the systemic coagulating functions are also important. So this is actually in the early stage of the diagnosis. Now we know that the coagulable state, or especially DIC, is an important factor contributing to important severe mobility and mortality in the COVID-19 patients in ICU. Obviously, so we also develop a prognostic model that can be used to stratify the patients, high risk versus the low risk patients, and this is important for physicians to identify those patients earlier and then intervene. So finally, we made this system open to all the radiologists and the clinicians, and then so you can download the slides and slices and also the codes. So this is actually now available at the China National Center for Bioinformation, and as it is now, it's being viewed almost 10,000 times and downloaded for now actually 3 million times. And so this is actually we're happy that a lot of people worldwide have been using them and for their actually diagnosis. We also are collaborating with several other leading institutions and in different countries to actually advance this and try to actually make combine data and the algorithms to make them more generally accessible and also applicable to the COVID-19 disease. So with that overview, I just want to actually acknowledge my collaborators, and so this is actually a collaboration with many institutions, and then I'll stop here, answer questions. Thank you very much.